Welcome to the Translate Your Doctor podcast. I'm your host, Patrick Figures, joined as always with my co-host, Dr. Trey Sertish, and today we are talking about the stigmatization of disease, which sounds very exciting. But before we jump into that very exciting, very fun topic, Trey, I think it's important context to lay the foundation to talk a little bit about compassion fatigue and burnout and those elements that care providers, nurses, physicians go through as it relates to being able to connect with what the optics of something might look like to a patient. And I am genuinely curious. We try not to talk about these things in advance so that we can have an authentic dialogue here on the podcast. How much of that do you see and have you experienced as someone that's known for being very compassionate and very empathetic with patients? It's one of your superpowers. Do you feel like you've had to fight this level of compassion fatigue and gallows humor? And how much of it do you see across the profession in your professional experience?
Yeah, I think that likely if you counted up the amount of encounters that healthcare professionals are having with patients and with themselves about patients, it's a minority. I don't have a number necessarily, but it's likely a minority. But the ones that you think of that are truly mean-spirited are very rare. I don't see that often. And the ones that are, like you talk about, gallows humor and somewhat trying to make light of what is a objectively terrifying or horrible situation, that's a little bit more common. And again, it just speaks to how do people respond to what, again, are very challenging, scary, sad, tragic circumstances to make them more tolerable over time. Because I think unlike most people who are dealing with a death, say, of a loved one, that is sort of not a one time, but in that moment, a one-time response. But if you're a person who is moving from worst situation of that person's life to the next room, to the next room, to the next room, and they're all sort of the same flavor, if that's just how the dice rolled that day, that can be really hard on somebody. And yes, it's what we train to do. Yes, we're very good at it. Yes, some are better than others, but it still always takes a toll, and different people have different mechanisms to kind of compensate for it.
I was recently in an emergency room environment with a family member. Luckily, everything turned out okay. But I caught myself going through this mental process of thinking, gosh, please don't let any of these nurses or doctors give some incredibly cold take that I can overhear. Even as a medical insider, like, I get it. A nurse showing up to work, a doctor showing up to work, it's just their job. And their job is to care for people. And they likely do a phenomenal job of doing it. But there's a degree of cognitive dissonance that goes on where this may be the 100th or 1,000th patient you've seen this month that has some issue that you know is perfectly benign, but the patient doesn't know that.
Right.
And the patient is very anxious and in this heightened emotional state. And you're stepping out of the exam room and you're rolling your eyes and you're like, oh my gosh, we got another one. And there are all these lovely terms that care providers have for difficult patients that don't make it easy on the providers, on the nurses to care for them. And it creates these comical and sometimes not so comical misunderstandings when you have a care provider make a comment that they shouldn't make. There's a famous, I think, emergency medicine, ER nurse, ER doctor slogan that was popular when I was managing hospitals. That was, we're here to save your ass, not kiss it. That was incredibly charming, very funny, humorous for healthcare insiders. And as you can imagine, not entirely well received by the public at large when the nurse walking into your exam room is wearing a we're here to save your ass, not kiss it t-shirt.
Not having been at that institution and get the context, and there are jokes and so on, but just understanding that no matter your political leanings, medicine is an extremely conservative, and I'm not talking politically, I'm talking just in terms of how do you approach these very sensitive topics. Very conservative profession. It's one of the most conservative professions. And so anytime you're doing things like that, you really got to ask yourself, how will this be interpreted? Because, again, somebody's children could have died in a car accident when they see that t-shirt. And do I want that person who made that t-shirt to be thrown out and all the t-shirts burned? No. I mean, it was sort of in poor taste, but I can also see where that comes from. I can see the stressors that lead to that because you feel like your job as healthcare provider is to provide healthcare. I would push back and I hold myself and my learners to a high standard. I don't always meet that standard, but I hold myself and them to that, which is that you do offer more than just saving people. Because I would also push back on that emergency department and say, how many people are you really saving a day? Pretty rare. You're not seeing that much life-threatening illness hour to hour, day to day. A lot of what you're seeing is, again, in this country where primary care is fragmented and difficult to attain, particularly in an acute care setting immediately, a lot of what you're seeing is low acuity disease. Vast majority of what's moving through emergency departments and hospitals, even at large academic centers such as the one I practice at. And so all I would say is that, well, if you're not saving that person in that moment, and you're not, as it says, kissing your ass in that moment, what are you offering to your patients other than making them feel belittled for having their problem?
Yeah.
So again, I don't want to lecture. That sounds really lectury, but I just think that you just got to ask yourself, but I feel my heart goes out because I think we've all felt it, myself included, when you're dealing with feeling like what you're doing should be enough and isn't.
And it's become a trope in medicine. The notion of compassion fatigue. It may not be the Dr. House syndrome specifically, because that's a unique case, but it is a common archetype for the burned out physician that they close themselves off. They care so much that they've had to close themselves off, and really that's just their body armor is making jokes and being cynical, because deep down they just, it hurts, and they had this tragic thing happen in their first year post residency that caused them to, they'll never love again. They'll never love a patient again.
And I think it's that and more. I know that you're saying that tongue in cheek, and it's true, but it's that and more. I mean, I have met and felt at certain points where jokes need to be made because it was a terrible circumstance, and you don't have time to just sit there and cry at the end of the credits of the tragedy movie, right? The movies give you the opportunity to be like, oh, I can express my emotions now, and that is a finite period of time. But if you're working, and the beauty but also challenge of medicine is you don't know what's going to come, you don't know what your day will look like, that you feel like you have to ration that emotional energy if you want to be an effective, compassionate person. And there are some who are better at rationing, but there are also just some who have a deeper well.
Yeah.
And again, people manifest it in so many different ways.
I think it's a good foundation because it contextualizes this difficulty back to patient physician or patient healthcare system relationship, where there's a known trope for the compassion fatigued nurse, the compassion fatigued physician. We're here to save your ass, not kiss it. Known trope. And patients feel scared of that, defensive about that. And then healthcare providers also feel that to some extent they've earned the right after a long shift or after 5 shifts back to back to not need to feel like they're just rolling out the red carpet and just like, oh, whatever you need. Hey, look, this job is tough. I've got 27 other things going on. I need to be able to just the facts, ma'am, without a smile on my face at every single second. So there's this challenging quality on both sides coming into that interaction.
Yeah, moral licensing, which is what you're describing, is a concern. It's natural, it's understandable. You see it in different industries outside of medicine, but it doesn't mean that it's excusable, I guess is what I'd say, or that's the standard we want to hold ourselves to just feel, and I know that's not what you're suggesting, but to feel like I had this sort of day, therefore I deserve this kind of thing. I would argue that how many times as a physician you've heard someone say, I struggle with alcoholism, but I work really hard, and at the end of the day, I want to have my, 3 martinis in a row. And I think the physician would say, well, you can't do that. Like that it's just that simple. And whether or not that's helpful is another discussion. But I think we can all agree that it's no different than saying, like, I had a really hard day so far. I get to treat you in a way that I wouldn't treat a loved one. Okay. It may be how you need to be treated in that moment. You've already mentioned difficult patients, and that is itself another episode, is like what defines a difficult patient. Because there are people who are just mean. People are mean, right? Doctors are mean, nurses are mean, people are mean. And sometimes you have to be curt and establish boundaries with people who are being violent or verbally abusive or, I wouldn't say ridiculous, but just have standards that are outside of what can be delivered. So sometimes that is necessary. But is that the common circumstance when the person who is doing the moral licensing is saying, I can just treat this 66-year-old grandma who came in with, a sprained ankle curtly? Like, I don't know if you do that to your 66-year-old grandmother who came in with the same problem. So
That's well said. The next part of that conversation, why does the medical industry come into this? What is their deal? What is their problem? Why are there jerks? Too many, so many in medicine. And here's the argument they would make, which is compassion fatigue, burnout, all of these things. And you illustrate perfectly the next point, which is, and no one cares when you're in the exam room for this very, very specific reason. In the exam room, in the hospital, there is such a wide power differential. The patient is so powerless to advocate for themselves that honestly, for the doctor, for the nurse, there's nothing that patient can do to you. There's nothing. They have no tools in that interaction. You walk into that interaction having all of the knowledge, all of the power. The patient can drive so little decision making. And there are these terrible, tragic stories about patients being convinced and being right that a loved one is having a terrible event right in front of them and just having no idea how to communicate. Like, I think something really terrible is happening to my mother. Right. Help, please, someone.
Right.
And that's what necessitates, as you just said, the repeated messaging that you and I both believe to healthcare providers, which is, it is an unfortunate cost in the industry that it puts such a burden on our care providers. It is truly terrible, and it never excuses punching down on the patient who always has the least amount of power.
It's very challenging because I interact with a lot of learners and my own practice, and there are times when you're exhausted, and there are times when you're interacting with people who are perhaps more exhausted and more wrung out and can't provide the care they themselves know they need to. And that cognitive dissonance, that emotional dissonance, really drives people to act in different ways. And I'm not excusing it, because I wouldn't in that moment. I think that I would say you have failed that patient, and I think you failed yourself, and I think that you did that. And some people have a capacity in that moment to sit with themselves and their actions and have that conversation and be like, you know what, I made a mistake. I told a lie, like if you're a kid, like I told a lie and I'm going to do better. And that's fine. I think we're all imperfect beings who are constantly changing. But I think what happens is that, like you're describing, that power differential exists. And if you're not forcing introspective on yourself, and you don't have close allies who can call you on those things, or at least engage you in a discussion that's safe, you'll just continue to do it. And that moral licensing that you're taking will become your practice. And before you know it, it's contributing to what is contributing so much to dissatisfaction in medicine, which is the erosion of those relationships with your patient. Because if the patient is the enemy, if the patient is the source of your stress and the way you feel, which is, again, largely your fault, but that's strong verbiage. But in this example we're using, largely your fault because you didn't take the time to introspect and really reflect, why do you feel that way? Then you can't help but with every interaction feel like you're combating something when it shouldn't feel that way. It should only feel that way those rare instances where you're combating someone.
It shouldn't feel like resistance to inhabit the core elements of your profession.
Right. I think that many patients would perhaps listen to that, what you're saying in terms of physicians holding all the power, and think that that's wrong, and perhaps that it is. But the way that we've structured it is it's seemingly necessary. And the thing we've done to help with that is to, again, in medical education and training, to just constantly hope that the people they're exposed to, the mentors they have, the curriculum they follow, all of these things, hammering into them over and over again, you can't take that for granted. And it's not a perfect system. So I'm just reflecting on it.
Well, it's a good backdrop, and this was really meant to set a groundwork for the discussion that you encouraged us to have around stigma, because this is the first step on the staircase that leads up how challenging it is to have open communication between physician and patient, especially when it's something that's become stigmatized in our society. And you and I were talking about this notion of there are disease states that have stigma associated with them. Lung cancer, right? Someone has lung cancer, and there's this quality of like, well, you shouldn't have smoked. Shouldn't have been a smoker. If you smoked any cigarettes, your fault that you have lung cancer. Stigma associated with that. Sexually transmitted diseases, STDs, STIs. They, of course, have an enormous amount of stigma associated with them. Any obesity or weight-related illness, oh my gosh, has an enormous amount of stigma related with it. And that in and of itself, that stigma, combined with a fear from the patient of being made fun of, being ridiculed, being looked at, and hearing that, well, you did it to yourself. Ugh, what a miserable thing to have happen. You walk into an environment that has a natural power imbalance. You have images in your mind of the compassion fatigue, the Dr. Gregory House as the physician that you're going to see. And there's a viral TikTok video that went out a couple weeks ago about a patient that walks in. She's having these GI issues, stomach pains. She can't hold food down, and she's overweight. And she says to her physician, like, I'm unable to eat. And everyone knows what's coming next. The physician says back to her, well, maybe that's not such a bad thing.
Right.
Rushing, just like a comically, truth is stranger than fiction. It's like there's no way someone, a grown person with the responsibility of care, heard a patient in pain and suffering and vulnerable say to them, I'm having such discomfort I cannot eat. And with a straight face said back to them into their face in the room, maybe that's not such a bad thing.
Sure. And obviously not having seen the circumstance, I tend to think, because I bet you, perhaps I've never said anything that's devastating, but I replay the film in my mind about what are the things that, I think this exists both ways. You recall when you're like a kid or even older, when you're in college and stuff, and just interacting with, I use teachers a lot because that tends to be the kind of unifying thing, but like people who interacted with you who like changed your life. There's just like, you had one conversation with this person that just like etched into your brain, and you can't ever imagine it could be good. In this circumstance, it was bad. And if you saw that person 5 years, 10 years later, and you said like, hey, do you remember when you said this? And stuff, and they're like, I don't, like, who are you? Like, I don't even remember, like, and they're not meaning to be mean in that point. But what I mean is that like, we don't know when we're in a position of power or admiration, okay, or respect. We don't know what the things that we say, how much weight they're going to carry. So I wonder, this sounds like pretty callous, but I do wonder, I mean, again, it's just one of those moments where that physician's just a person, and I just find it so hard to believe that somebody would just dunk on another person. It does happen. And in that instance, it's pretty easy for you and I to just say like, that's wrong. But that doesn't speak to, like, just saying something is wrong is obviously not what our system needs, right? Like, it needs more nuanced discussion about like, well, then why are we here? Because if it's just as simple as you're wrong, then the fix would be pretty easy, which is just identifying that that's wrong.
See, and I'm going to sideswipe this line of conversation, right? Because like, think about what we're doing here. It almost doesn't matter if it actually happened. The fear of it happening is real.
Yes. Yeah.
And that is what patients are fighting, right?
Yes.
And you've seen and experienced compassion fatigued providers. And it's not a stretch for you to imagine some of your colleagues doing something like that. Now, of course, what we are not going to say is, well, you should just get over it. Because it shouldn't happen. It shouldn't happen. It should never, ever happen. And it is a crime. That's obviously hyperbole. It is a tragedy that you and I on this podcast, the podcast for patients, as you and I think about it, to empower and equip people that we care about who need help navigating the system. We have to prepare them for this. That is what literally you and I are doing right now.
But I agree. Think about this, though. I think it does speak to what translates your doctors about, at least one of the things, which is how, because I reflect on it, you're going to say, like anybody, you are going to say something at one point that's going to upset another person. And odds are your intents are good. Most people are good. I truly believe that. most people are good, and so most people's intent is good, but nonetheless, you're going to put your foot in your mouth at some point. And if it's with a loved one, odds are, right? That's who you're usually talking to. If it's with a loved one, generally in those circumstances, you can say, that person can say right back to you, like, oh, that hurt my feelings, or I am upset, or I can be visibly upset with you. And that will not make the conversation stopped abruptly. It will allow, hopefully, a conversation so that you can hash out and say, like, that really hurt, and we can move forward and have a relationship that continues to grow. In fact, it's stronger now. And that's what Translate Your Doctor is about, right? Which is getting people to recognize that your relationship with your physician is a relationship, is not just an interaction. Because if you want it to just be an interaction, you could roll double snake eyes and get this woman's poor episode, right? Where someone said something very hurtful, but that's the end of the interaction, and she leaves.
A relationship by definition is reciprocity, right? There's balance. There's balance to a relationship, 100%. And Michelle, Dr. McClelland, highlighted this with her. A relationship allows room for fallibility, which is what you're talking about, right? Which is and there is relationship capital that can be used both ways, built through successful interactions, and it can be lost through unsuccessful interactions. And Dr. McClelland talked about that with this "oh, by the way" quality, which triggers a lot of physicians who feel compressed in a day, and then when they feel like a patient is not respecting their time, which of course is not what the patient's doing 99.9% of the time. Patient doesn't know. The patient doesn't understand how to properly consume healthcare. Patient's like, oh, by the way, while I'm here, I almost forgot to mention
I also have this other issue.
Yes, and they're like, no, you don't, because I don't have time. You don't have another issue. I think we're done. Which, of course, is unskillful. Of course, shouldn't happen. And with a proper relationship, you can navigate that. Dr. McClelland on that podcast, everyone should go listen to it, gave a wonderful example of how that interaction should happen, which is Dr. McClelland circled back with that patient and apologized, because that is the missing piece.
Exactly.
That is the point with this. And this highlights, but I'm gonna keep you back to why we're talking about this, so we don't get too lost in the ether. Which is, the point is that this is the thing blocking the relationship. Once the relationship is established, of course it's easier to navigate. But as a first principle, if you're trying to establish a new relationship with a doctor, and whether this happens or not, it is the fear of this happening that dictates the relationship.
Absolutely.
Brings the patient into the room with this level of, I start out defensive. It is hard for patients to talk about anything that's stigmatized, because there's almost this level of like, how do I prove that it's not my fault? Or how do I, not be made fun of in this moment? Like, it's hard for patients to be vulnerable because of the fear of stigmatization.
It's so many things. I mean, because and this is what I love about medicine, but it's also so difficult. You talk about the stigmatization, which is absolutely true, because physicians are people, patients are people. We keep hammering that down. And a relationship, again, is a tool to better facilitate different people coming together. That's what it's meant to do, ideally. And you're right. If you're coming in the first time ever and you don't have any preconceived notions about this doctor base other than your past experiences, whether on television or radio or in books or personally or with your family, what have you, that's really hard. And
how do you, so let's make this valuable and useful. You and I can do this all day. How do you manage this? You teach me. Like, how do you see this every day? People that have STDs, people that have morbid obesity, people that have things, and I'm sure I bet you see this scar tissue from people. Let me give you a brief example. Something that I saw every day at the primary care clinic, the family medicine clinic that I worked at, which was patients would come in, and on the chief complaint or reason for visit, it would say, oh, they have like whatever hangnail, and they'd do a workup with the MA, and then the doctor would come in and they'd be like, okay, look, I don't have a hangnail. I've got syphilis, or like whatever. Like, I think I've got some, like, which is, it like speaks to like stealthing. Is that the term? Is that a
no? I just say it right now, but that's like
it's a trade term. Absolutely. Like, it speaks to this, like, this emotional charge. That's an emotionally charged conversation just by the nature of the deception that happened. It's like, okay, we're going to need to navigate this very carefully. How do you handle that?
I think that for a variety of circumstances, making it normal for that person Does that mean that it's normal? No, because I do think that there's an importance in society and in medicine to be like, you may have done something to contribute to your health problem. And we have to acknowledge that before we move forward. But if you didn't, it doesn't matter. It doesn't change my approach per se, because that outcome is what I'll say normal for you. It doesn't make it normal in terms of physiologically, like that. But this is who you are, like coming at me, whether you're struggling with substance abuse, morbid obesity, not taking your medicines and getting sicker, any number of things. And I think you got to meet people where they are. And so the way I think about it is that I generally just like to ask questions. And I'll say, well, you're coming here with this problem. We'll talk about this patient that you're making up with, who's told the MA one thing, but then tell you I'm here for syphilis. I'll go, okay, well, why did you feel the need to tell me something in the MA different? She works with me. And it was like, well, I didn't feel comfortable because I wanted to tell you only. It's like, okay, well, it sounds like you're having, you correct me if I'm wrong, but it sounds like you're having difficulty accepting about this diagnosis. Is that true? And depending on what they say, well, yes, like I really, I didn't think that would happen. Or yes, I got this because I was unfaithful to my wife and I don't know how to get around it. And so like you hear all kinds of things. And I think I would just ask like, well, what bothers you more, the disease or the societal implications of what you have? The stigma, like you're saying. And some people may know, some people may not, again, not a lot of people just have they just kind of understand like, this was a bad thing I did. And that like, I need to not have this anymore. And I just need you to take care of it. And I'm not going to engage with you on that. And if that's the case, then I'm like, okay, well, then let's talk very simply about the mechanics.
So walk me through your mindset of that, right? That's an isolated example. Expand that out to a rule. Like, what would you call that rule? What would you call your approach to like something where you feel like, okay, this has got a little higher stakes to it?
I think that like compassionate questioning, just like trying to meet the patient where they are and why they feel that way. That doesn't work for the example that you gave, I would say, right? In terms of fixing this poor woman who came to this physician and said, I can't eat, and he said a callous remark. I think that if I had to think in that instance, the strategy the physician was attempting to use, if it indeed, I'm given huge benefit of the doubt, but the strategy was perhaps, I don't have a solution for your problem. That makes me feel insecure as doctor because I'm meant to have solutions. And therefore, I'm going to minimize the problem however I can, which is dismissing it out of hand, making a joke about it, redirecting to other issues like your weight and so on. And to fix, again, the core insecurity, which is I can't fix your issue. My solution, like you're saying, is that regardless of whether or not I can fix your issue, I can understand it. And if you understand it, because there's a lot of people who haven't even gotten there. And if that's the case, then let's get you to a way of understanding.
There's something even in your sharing that pops up to me, and any patient that's listening to this that is bringing emotional energy into a conversation with a physician. If you have something that you feel is stigmatized, you feel like there's a stigma around, ironically, that's a great way to shop around for a physician, because if you find someone that handles that skillfully, you've probably found a good advocate. You've probably found someone that's going to be a good partner for you in your health. Those high stakes conversations, that sword cuts both ways. It's very scary because you can have a really terrible outcome. And that's very damaging to the physician's reputation if it was a simple misunderstanding, and obviously damaging to the patient psychologically and their relationship to the profession, their relationship to healthcare, the traditional healthcare system, because they will tell that story forever about how healthcare failed the average patient. But it's also a chance for repair, and it's a chance to build trust. Yes. Because if you handle that interaction skillfully, if you handle that interaction with care, compassion, love, building trust, wow, what a powerful story. What a powerful way to rebuild trust with the system. Rebuild trust that there are good doctors, quote unquote, good nurses, good whoever care people out there. Because everyone has a terrible healthcare story. I hope everyone also has wow, I really interacted with someone, like you said, that made a difference, that made a positive difference with me, even if it was the most banal thing in the world.
I agree. And like we're talking about, this podcast, Translate Your Doctor in General, is not meant to be a passive thing. It's not meant to be, I hope I win the lotto with my doctor and stuff like that. You're talking about shopping around, but a lot of it is appraisal, right? Like understanding, does this person offer me that? But I don't think a lot of people logistically have the luxury to just be like, well, I'm going to go Like for a used car, I'm going to go to the different lots. I'm going to try all these doctors out. I'm going to see which one fits and stuff. Sure, maybe people are lucky enough to do that. But I would say I'm distilling it down. But even in 7 out of 10 doctors, you know what I mean? And what I mean is like they are quality 7 out of 10. They're not a 10 out of 10 and so on. Even in middling physicians for kind of capacity to be compassionate and understand you, we translator doctor want to give strategies to patients to get the results they want. Mm-hmm. And again, it gets back to those kind of original tenets we talk about in the introductory seminar, which is like, know what success looks like to you. What do you want from that interaction? I think it's important to understand what you don't want, because getting back to this woman's example, she didn't want to have her weight involved, and that's harder. Like negatives are harder.
Let me challenge that. Maybe it would have been appropriate to get the weight involved. I don't know about that whole interaction, sure. But the doctor made a joke. Made a callous joke.
Right. Like
it's about the joke, I think.
Yeah. Well, I guess what I mean is like it's harder to have rules that are negatives, right? That to say like, well, I don't want this, I don't want that, because it's a bit hard for the next step to find and advocate for that, because it's hard to just be like, well, I don't want a doctor who likes bell peppers on his pizza and stuff like that, and you got to go about finding that. It's much easier to be like, to ask questions and to figure out, it is valuable to me that when I am vulnerable, that my physician meet me and understand that I'm vulnerable and take that seriously. And one does not in the first 20 minutes have to have that conversation with a doctor. But I think that, it's very easy to ask somebody, it's like, if I have something really hard that happens to me, like, what is your strategy for me to bring that to you? How do you want me to bring that to you? Like if I'm really struggling with it, it's not right now, I'm just coming in because I want my physical and I'm meeting you for the first time. But like in the future, I assume something's going to happen to myself or a loved one. How do you want me to bring that to you? That doctor may not know in that moment. That doctor may be like, what? I don't, no one's asked me that or something like that, but that's going to plant a seed to at least start that. And I bet you 9 times out of 10, when you do bring that thing, they're not going to make a joke because they understand you took it seriously.
And credit also to Maggie Teleska from the Congestive Heart Failure Support Group, because she talks about that one of her elements, one of her winning formulas when working with a physician is to ask that question, like, hey, how can I best work with you? What do you need to hear from me so that you can best understand me? How can I package what I'm going through in a way that you can understand? And getting the physician to say explicitly, like, oh, well, here's what's helpful for me to know. Here's the knowledge I need from you to best care for you. And isn't that a two-way street, right? Yes. Also, the physician being able to say, hey, how can I package this in a way where you, patient, feel like you're really understanding what I'm saying? Yes. And that exchange of trust, and also the political capital, the relationship capital you get by saying, I am willing to meet you halfway, because that's a way to say, I'm willing to mold my style around your stylistic preferences, right, which is a way to give control, to even out the power imbalance in the room. Because a tributary of this conversation too is this idea of patient-led, I forget the name of it, where like the patient is a collaborator on their care plan. Help me with that term.
Patient autonomy?
Yes, like this patient autonomy movement where it's, I'm not telling the patient what the plan is. I'm suggesting multiple avenues to the patient. And
shared decision making.
They are shared decision making. That's what I'm looking for. Because I think all of this is part of that same dialogue. And all of that only works with trust, with a relationship, and the stigma conversation and the shared negative storytelling that can happen between physician and patient blocks that relationship, which was the theme of this.
Yeah. Would you have ever shared your favorite toy with someone you didn't trust? That sounds
absolutely
ridiculous.
Not. No, it doesn't sound
but
ridiculous.
It's like the same thing.
Yeah, 100%. That's a very simple and easy to understand analogy around one of the big blocks in the system. And it's unfortunate because it's so important, especially you and I have talked a lot with the Congestive Heart Failure Support Group recently. We really enjoy interacting with those people because those people do have a tough road to hoe because of this longitudinal challenge, right? Anyone with a life-altering illness has this longitudinal need to have a very effective, high-fidelity relationship with the healthcare system. They need the most help. And so you and I have felt really called to lean in with that group. And man, there's so much around trust and relationships even there. And every time we hear about this inelegance, the inelegance of the system handling these people with life-altering illnesses, you and I just cringe. It's just so incredibly painful.
And it leaves a lot of the unfortunate thing about that too, that we're not talking about, that could also be another episode, is that it leaves a ton of room for bad actors as you talk about it.
Yes.
Because people will go look for that relationship no matter what. And it can align with people who are giving good, sound medical advice and doing the right thing for you. And it can align with people who are fast talkers and saying what you want to hear and doing what you think you need.
With excellent marketing departments and
Yeah.
commercials and
Yes,
using the tricks of the trade to build.
Absolutely. Which is like kind of what we're talking about in terms of like, look out for these things in terms of good stuff, right? With that, people are listening to you and people are engaging with you and people are validating your concerns and fears. And that is all excellent. It's a shame though that it can be difficult to differentiate that, because like you say, that dichotomy of power is so great that you can't, like, I wouldn't be able to tell that for a mechanic for my car a lot, right? I mean, you may get burned once and you're like, well, I'm not going back there. That seemed, but it may not be so simple in healthcare. So that's I think the other side of this, which is also damaging.
This was your great suggestion for an episode, Trey, and we did our thing of sort of careening all over the road to try to cover a nuanced, deep topic. Anything you want to add, and did we get to the heart of what you feel like you had to say around the stigmatization issue?
I think so. I think yes and no. I mean, again, you do talk on, I mean, it is, when we start leaning into nuance, it can be meandering, and we're combating that. However, I do think that always coming back to like what translates your doctors for in the circumstance in which we're talking about. And if one can advocate for a relationship with their physician, then one can talk about stigmatized things, ideally, understanding that the world is imperfect and doesn't owe you anything, but you can work and make effort to build the world that you want, or at least can tolerate. And I think that's the same as it applies to physician-patient relationships, which is things might be unfair. Some person, both patient and physician, MA or nurse, the receptionist at the front, can say something callous or well-meaning, but very upsetting for whatever reason. But we can work through that, and not everything can be worked through, right? You can't marry everyone, but you could probably marry a lot of people and make it work. And I think that that's inherently how we should think about the patient-physician relationship. And that's what I would advocate for, again, translate your doctor, which is understand what you need, advocate for that thing. If you can't get it through diligent work, then look someplace else.
That's an excellent last word on this topic. Shameless plug. If you're interested in hearing and seeing the full 16-minute introductory lecture that Trey gives on sort of the Translate Your Doctor philosophy, head to our website, translateyourdoctor.com. We're going to revise the website in the next couple weeks as soon as we get time. But you can sign up for our mailing list there. Everyone that signs up for our mailing list is going to get that introductory lecture, and then you'll also get regular updates about talks that Dr. Sertish will give and things that we'll be doing out there in the community to try to espouse and advocate for patients. Head to, if you want to send us a comment, question, you can email us at translateyourdoctor@gmail.com. Pretty straightforward. Please go ahead and leave us 5 stars. Leave us a comment on Apple, iTunes, Spotify, wherever you can. We're just trying to grow the word of mouth, trying to help people out. We're interested to hear what's been useful, what hasn't been useful. We're serving you, listener. You're our customer for this podcast. Very interested in trying to take this dialogue that Trey and I are having and distilling it down into really useful information for you. So as always, we appreciate you giving us a shot at some of these messy topics, but we're trying to have the sort of dialogues that you're not hearing other places about these topics in medicine. Trey, thanks as always.
Yeah, thank you.